this is a 45-year-old female with chronic history of asthma, and they sent the patient to HRCT. And I'm going to scroll down. Can you put your answers in chat, or you can tell your findings, and then we will go over what are we seeing and how we are formulating the diagnosis. It's a HRCT 0.6 millimeter reconstructions. This is the inspiratory phase. I have an expiratory sequence as well. This is the expiratory sequence. I'll put both of them side by side. So on the left is your expiratory sequence. On the right is your inspiration. Patient has history of asthma, and they want to evaluate what is going on. Okay, someone started answering bilateral mild tractional bronchiectasis and interstitial thickening. So I just want to let you know there is no traction bronchiectasis here, and there is no interstitial thickening. So what we are seeing here on the anterior right upper lobe is minimal post-radiation changes, and you can see the patient has post-surgery soft tissue here in the right lateral quadrant of the breast, and also there is some evidence of post-radiation just limited to the anterior right upper lobe. So this is post-radiation. What is going on in the rest of the lung parenchyma? Excellent. Someone started air trapping on the expiratory scan. So on the inspiratory sequence, there is mosaic attenuation. On the expiratory sequence, you can see there is gas trapping. When we call gas trap, in order to call gas trapping, these are lobular areas of low attenuation present predominantly in the non-dependent lung. Also in the dependent lung, sometimes you can see due to gravitational forces, but when you're seeing it in non-dependent lung, more than five lobules in 4 different lobes, you call it as significant gas trapping. In this patient, yes, there is gas trapping. What else is the major finding? What is the thing which jumps at you immediately when you look at the scan or the inspiration? Someone said mucus plugging. No, mucus plugging has to be seen within the airways. It is kind of seen outside. What do you call all these findings as? Random nodules. Excellent. So random nodules, history of asthma with gas trapping. These are the 3 important clues to this diagnosis. Does that ring any bell? Chronic hypersensitivity pneumonitis will have central lobular ground glass nodules. It will not have solid nodules like this. Yes, that's a very good thought, but you should have like central lobular ground glass. So this is a DIPNEC, diffuse idiopathic proliferative neuroendocrine cell hyperplasia. Most commonly, what happens in patients with DIPNEC have it's a form of carcinoid. What happens is these will secrete neuroamine and neuropeptide, which will cause a inflammatory reaction in the bronchioles, which will cause localized bronchiolitis, which leads to gas trapping. And in this patients, you can see here, there are diffusely scattered random nodules, and also there is lobular areas of gas trapping surrounding those nodules. When you see these patients are inadvertently diagnosed as asthma for a long time, and they will be put on inhaled steroids, they will be put on albuterol. That is not going to help the patient. So 99% of the time, radiologists are the first person to diagnose dyspnea. Once you diagnose dyspnea, how you manage is, if at all they want tissue diagnosis, the bronchoscopist will go right into the bronchus and try to sample as many nodules as possible, and then they will they will look at the path specimen and they will give you the diagnosis of dyspnea. So the actual difference between carcinoid and dyspnea is this is not greater than 5 millimeters. It is below that. It will not erode into the basement membrane. So that's when it is called as dyspnea. When it is greater than 5 mm and then it is going into the basement membrane, then it is called as carcinoid. So follow-up regarding this is, if you are seeing one nodule which is way bigger than rest of the thing, just follow them based on the size. So again, the history is asthma, multiple nodules, gas trapping surrounding those nodules, dyspnea.